Good evening, everyone, and welcome to the fourth edition of the Anesthesia Incident Registry Rounds, an initiative by the Anesthesia Patient Safety Association of India. And as usual, every fortnightly, we are discussing two cases which have been reported in the DOC app anonymously as critical incidents from India. And to present this evening, we have Dr. Yogesh Paliwal and Dr. Bhuvneshwari. And to take the proceedings forward, I please request Dr. Archana Reddy to take over. Thank you.
Thank you so much, sir. Welcome everyone again to another exciting episode of incident reporting, and just to give us some experiences of what can go wrong during our daily practice and how we can learn from them. So we have two very exciting speakers today. First up, we have Dr. Yogesh Paliwal, who is an assistant professor currently working in the Department of Anesthesiology and Critical Care at Indraprastha Institute of Medical Sciences in Panipat in Haryana. And he'll be talking about gossipy Boma. I hope I pronounced that right. Maybe
Yes,
he'll
ma'am.
correct me in his talk. Yeah.
Yes,
Okay. It's a very interesting topic. And also we have next up Dr. Bhuvneshwari, who is an associate professor at AIIMS Nagpur. And she will be talking about what can go wrong in a vascular access, especially even when you're using ultrasound. So very interesting topics today, and look forward to hearing from the audience as well. We learn from everyone's experience here. It's open to all. So with that, we get started, and I hand over the mic to you, Dr. Yogesh. You can go ahead and start your presentation.
yes, ma'am. Is it visible, ma'am?
Yes, it's very visible.
So first of all, good evening, everyone. First of all, I would like to thank Dr. Bala Venkat sir, Dr. Sunil sir, and Murli sir for giving me this opportunity and to be a part of APSA. Today, I'll be presenting a very different topic and an unusual topic, although less related to the field of anesthesia, gossipy Boma, which is a forgotten sponge. So last month, a newsletter was published, and I found a very interesting case which drew my attention, counting out and left in retained surgical items. So what's the definition? Gossipioma is defined as the mass of cotton matrix left behind someone's cavity after a surgical procedure. We also call it as textiloma and cottonoid. Gossypium means cotton wool, and oma means tumor or abnormal growth. So a very fascinating case which was published in 2018 in the European Journal of Anesthesia, two pelvic masses, where a 42-year-old female was presented with a lower abdominal blotting since last 3 years. So she underwent actually for a cesarean section for 6 years back and 9 years back. On abdominal palpation revealed the non-tender masses in right and left iliac fossa. Abdominal radiographs were taken off, and in that they found a serpingeous symmetric lesions. In CT abdomen, a pelvic mass was contained with hyperdense stringy structures. A laparotomy was performed and two smooth masses were found, which were adhered with the greater omentum to the colon, and masses were resected out from the paracolic recesses. So finally, a diagnosis of gossipimoma was made. So incidence, although it is very rare, like people will be registering it, so the real incidence is difficult to determine because there are serious legal issues involved with it. So they are rarely reported. Surgical sponges left behind, the estimated is to occur is roughly around 1 in every 3,000 to 5,000 abdominal surgeries, and the overall frequency quietly falls between 0.001% to 0.01%. Gossipy Boma, which are retained surgical sponges, represent about only 80% of the retained foreign body cases. So what are the reasons? So human factors are also responsible, and simultaneously the environmental factors. In human factors, whenever there is a communication failure, across cultural, like surgeon to nurse, it is not properly communicated, or hierarchical, like captain to crew, for example, surgeon to the OT team is not communicated properly. Level of education also is very important, like the staff should be trained properly, and the experience also matters. In the environmental factors, the noise in the OT, distractions, the conversations held in the OT, traffic in and out in the operating room, and unplanned change in the surgery. So these all can lead to these situations. So the common retained items are like instruments during the surgery, surgical gauze or sponges, sterile towels, needles for suturing, and additional supportive tools or accessories. And for anesthetists, yes, throat packs are important. Common locations for gossipy are chest cavity, like pleural cavity, pericardial cavity, abdominal cavity, and pelvic cavity. So what's the pathology behind this? So these structures are non-absorbable materials, so they do not decompose. So the reaction can happen. It can be either aseptic fibrinous, which can cause the foreign body granuloma, or either exudative, which can cause an infective process. So the clinical presentation, they are very variable. Usually the patients are asymptomatic and there are incidental findings. So immediate post-operative, either they will come into the immediate post-operative period or some decades after the initial surgery. So patient may present with a palpable mass, abdominal discomfort, and more frequently the sponge is detected incidentally on routine post-operative X-rays. So what are the symptoms of gossipy? Discomfort or pain, palpable masses, vomiting, unexpected weight loss, frequent loose stool and diarrhea, and swelling or bloating of the abdomen, and a persistent urge to defecate known as tenesmus. So what are the complications with this gossipy are abscess formations, adhesions, obstruction, fistula formation, either peritonitis, erosion of the GI tract or urinary tract, migration of the sponges to some other cavities because of perforation. So what are the differential diagnoses of this gossipy hematoma, tumor, and abscess cavities? So how will we go for the workup of this patient? Usually the imaging studies will help us out. So since the symptoms are often vague, may not manifest until years. After the operation, the diagnosis primarily depends on the imaging studies combined with the vigilant clinical suspicion. In many institutes, the surgical sponges are embedded with radio-opaque markers, and nowadays actually majority of the institute are following this, making them easily visible on X-rays. And however, the practice is not universally accepted or adopted worldwide. So what options do we have to diagnose these conditions? Either we go with the non-invasive methods like plain radiograph, USG, CT scan, and MRI, or either the invasive, which can be diagnostic as well as therapeutic, which is endoscopic and laparoscopic. And majority of the cases, we actually go for laparotomies. So what is the value of counting? So a beautiful article in 2013 was published, retains surgical sponges and needles and instruments by Hariharan Lobo. So basically he gave an algorithm to us. So we should educate our staff first and standardize the sponge and instrument counting in the operation theaters as a regular practice. The lead surgeon usually is responsible to confirm the final sponge and instruments count is corrected. If any discrepancy is there, we are supposed to speak up loud. So, and it has to be very clear to the team. So if any discrepancy is there, so thorough cavity examination has to be performed. Low sponge should be found or instrument should be retrieved. If no, then X-ray should be done, or either a computed tomography can be done. If the sponge is found, it has to be an active intervention has to be done and it has to be removed immediately. So he also did a study on 90 patients, out of which the number of cases, one patient died because of the gossipy 40 patients were readmitted to the hospital, 62 were reoperated, and 26 had intra-abdominal abscess or sepsis, and 10 patients had small bowel obstruction, intestinal fistulation, and 5 patients had visceral perforation. So how to manage the situation? The approach varies depending upon the sponge anatomical location. Once identified, the patient should be advised for its removal. The retained foreign objects are usually removed by open surgeries due to excessive granuloma formation and adhesions, which makes laparoscopies and other less invasive procedures difficult to retract this out. For asymptomatic patients where the sponge is incidentally discovered, so it is advisable to remove after thoroughly discussing with the potential risk if it is left behind. So what are the prevention strategies? We all know that prevention is better than cure. So meticulous manual counts are very important before the procedure and after the procedure is concluded. This practice was formally established by a standard protocol in 1970 by the Association of Perioperative Registered Nurses, and an additional preventive measure has been endorsed by the leading organizations such as American College of Surgeons and Joint Commission, focusing on the avoidance of the retained surgical instrument in general. So let's discuss the history first. Before 1901, we usually do not found any kind of data which was suggesting of any counting. But sponge counting started in 1901, needle counting started in 1976, instrument count started in mid-80s, and counting of accessory items were done in early 1990s. So conduct the separate count at critical moments. So what are the critical moments in the operation theater? So before starting any procedure, the initial count should be done. After that, whenever any new surgical item is introduced into the surgical field, it has to be mentioned and has to be kept in the final counting. During the changeover of the staff, it has to be communicated properly. And before closing any body cavity, we have to see for the counting at wound closure and at the end of the procedure, which is known as the final count. So What is the role of anesthesiologist in this? So anesthesiologist must stay alert and practice safely measures to prevent retention of the surgical instruments. But situationally aware means identifying potential early risks early and acting to mitigate them. Anesthesiologists should not use any counted surgical items. Like for example, sometimes we do take some gauze pieces from there. It should not be done. It is essential for the anesthesia providers to confirm the removal of throat pack, bite blocks, and similar devices from the oropharynx and to clearly communicate their placement and removal to the entire perioperative team. So what are the emerging technologies do we have? So traditionally we used to manually count them. Nowadays, what we are available with is emerging to boost the speed and precision of these items is barcode scanning and radio frequency identifications. So these kind of barcodes will be present on the gauze pieces, so we can track them easily. Each sponge is embedded with the radio frequency sensor, and these sensors absorb the low frequency radio signals and sends a response back to the direction band and confirming the sponge location. Same with the barcodes, they can also be detected with the same way. So what we follow in our institute is the surgical safety checklist. As we can see here in the sign out, the nurse will confirm verbally at the end of the procedure the instrument, sponge, needle counts are correct or not. And we also mention it on the board as well. Like as you can see over here, a gauze in and gauze out has been mentioned along with the throat pack if it is applicable. Same with the needle in and out, we can do this. And apart from that, we have a separate stand for the gauze pieces so that the final counting can be easily done. So what are the financial and legal implications of such cases? So preventing the retained surgical sponges is crucial, not only to reduce the patient illness but also and death, but also to avoid the medical legal consequences. The financial burden of retained sponge can be substantial and often resulted in patient injury, prolonged hospitalization, and costly lawsuits. Additionally, the emotional distress experienced by the patient and the damaging impact on the reputation of the surgical team can be profound. So my take home message will be avoiding the retained surgical sponges is far more effective than treating them after occurrence. Employing the team-based multidisciplinary strategy can significantly reduce the risk of leaving such foreign bodies behind. Emerging technologies offer the promising tool to minimize the chances of retained surgical items. Clinicians should maintain the strong suspicion of retained surgical sponges in patients with previous surgical histories. When a soft tissue mass is found in someone who has undergone a surgery, a RSS must be considered as a potential diagnosis. Speak up, be loud, and clear if any discrepancy occurs. So avoid such situations. How can we do it? Pay attention while counting the sponges. Your few seconds can lessen the undue morbidity and mortality. These were my references. Thank you. At the last, I would like to invite everyone for the EURA 2026, which will be holding on 16th to 19th July in Coimbatore. Thank you.
Thank you, Yogesh. That was a very brief, very succinct presentation. Very good. Yeah, Murli sir, shall we open the...
Yes, we have the pleasure of Pankaj Kundra sir, who's just joined us now. I think sir was delayed. Sir, good evening.
Good evening, Dr. Murli. I apologize, Murli, I was stuck up, so I couldn't join.
No. Thanks for joining us, sir. Thanks for joining. In fact, we
I'm-
have...
I'm really sorry. I just wanted to apologize for being late.
No, sir, yes, it's okay, sir. Thanks for joining, sir.
Thank you for joining.
So the first incident which was discussed, which was reported on the app and in our newsletter, which was published last month, was the retained gauze following a surgery. So Dr. Yogesh Paliwal from Panipat presented the case and also some of the evidence surrounding it as what he calls it as gossipy boma. Gossipy is the name for cotton, and the oma is the retained whatever tumor-like structure. So it was a wonderful discussion, and the importance of sign out was very well stressed. And also Yogesh said that the anesthetist should not be on their phones, but actually listening to the gauze count and the counts that are happening. Pankaj sir, along with you, we have other senior anesthetists here with us, Dr. Vandana Mangal from SMS Jaipur, Dr. Sajana Mukundan from Manipal Hospital in Bangalore, Dr. Manopan Madpu from Fernandez in Hyderabad. So I request the participants to kindly engage with the senior faculty here, and we can discuss this incident.
A very good evening to all the panelists and the person who is presenting. Thank you so much.
Thanks, sir. So, sir, we would like to hear from you a little bit about the importance of anesthetist in this gauze count and retained either needles or instruments or mops or gauze.
Yeah, I agree, Dr. Murli. The main thing is that normally what we do is that you do a sign out, but the thing is the nursing staff usually keeps the count for needles and gauze pieces. So what we had decided was that we will put it on the board. So once it is written down and put it on a board, I think everyone becomes aware when the count is being done that this was the count and now this is what is the count is. Because at times it happens that even the anesthetist would like to have a sterile gauze for some procedure and the sister would give it to them. And then we throw it into the bucket and that's where the problems can also occur. So I think it's a wise idea to put it on a board, at least the Gauss count. We even tell them to calculate the blood loss and tell them how much is the small gauze, mid-sized gauze and cotton pads, how much it has soaked, so that even the surgeons are aware of what kind of blood loss is happening. So that's the only thing I can add. Thanks.
Thank you, sir. I'd like to listen to either Dr. Vandana or Dr. Manokant or Dr. Sajna to just highlight a few points.
Hi, Dr. Murli. Good evening to everyone. Dr. Sajna here. So, in our institution, we do use radio opaque gauze on the surgical side, and on the anesthesia side, for whatever procedures, we use non-label gauze. So, once the anesthetic procedure is done, it is usually discarded away, and the surgical gauze count is kept in view. So, in spite of all this, we do have incidents of missing gauzes and all that. One thing I would like to reiterate is counting of the gauzes at the beginning of surgery. It has happened many times that there's an extra gauze count in the pack right from the CSSD. So if that happens, if the nurse is not counted properly, we can still miss a gauze inside the peritoneum or in the surgical side, and we might think that the count is correct. So importance of counting the gauze at the beginning, even though they send it in packs of 5 or packs of 10, we have to make sure that it is correctly counted by the nurse who is doing the scrub nurse. The second point, again, which I would like to make is sometimes when a surgery is over and the whole OT is clean, some gauze from the previous surgery, the radio label gauze, might be left by accident. And suppose we think there is a missing gauze and go and fully try to look at the OT, cleaning up every small space, and finally find this missing gauze and tell that, yeah, this is accounted for. Again, we might be missing a gauze piece inside the patient. So I think after every surgery, it should be made clear that the OT should be completely clean and all the dustbins should be cleaned completely. That should be ensured. So these are the places, in spite of our counting being right and being very vigilant, we can still miss a gauze inside the patient. Thank you.
Yeah.
Thank you. Yes, sir, Manok.
Yeah,
Go
just
ahead.
couple of so I agree. So we do the same thing. So we initially on the board write up all the things so that everybody is aware. So they open the cesarean section kit. So how many needles, how many gauze pieces, how many different instruments is written on the board, and then at the end it is matched before closure of the rectus. Just couple of incidents. So we had couple of incidents where we couldn't. The surgery was done. Everything was closed just before counting. I mean, they couldn't locate the needle, the surgical needle, and we had to search everything and ultimately we got it under the OT table or in the surgeon's drapes and things like that. So we had a few scares with the needle, and recently a small baby, so everything went well. X-ray was taken with the gauze piece on the first. So it was a surgery for intestinal obstruction on the baby. So first day they took an X-ray and they saw the gauze in X-ray. Suddenly there was a scare that we forgot the gauze inside, but turned out they took the X-ray with the dressing gauze, and thankfully nothing happened. So these things can happen. So we had a couple of scares with the needles actually. So we have to be careful, especially at the end of the suture they cut and then that gets misplaced.
Thank you.
Yes.
Thank you, Manokam. Thanks a lot. Any other inputs or any other points that we can incorporate in our day-to-day practice?
Yeah.
Okay, should I saying something, please?
Go ahead. I'll speak after you.
Okay, so the anesthesiologist, besides that writing and all, is a observer and an additional person who has heard, who should carefully hear that what counts are being announced and are they correct, should keep a very vigilant eye, because anesthesiologists are very keen observers. So we should be keenly observing that the counting is being done properly at all points of time, before and at the end. Because at times, a lot of things, as Madam has said, that it is assumed that this number of gauzes are there and one doesn't tend to count, and there might be more or less. So anesthesiologist has to use that. Thank you.
Okay. Thank you so much, ma'am. Very valid points. I just wanted to add two more points, actually, Murli sir, to this discussion. So I think, yes, we do have to be vigilant about it, but at the same time, all of us have to remember that we should not disturb at the time the counts is being happening. Sometimes, at the end of surgeries, we're all in a rush to get it over. The surgeon is in a rush to get it over. And, but that's the one step of the entire process that should not be rushed. Especially, we should be strong advocates, even when we have junior staff, scrub nurses who are just on the learning curves, and, the surgeon sometimes, or even sometimes we bully them and say, come on, hurry up, sister. I think that should be avoided at all costs. We should at least, with the very minimum, be silent and allow them to do that job that they're doing. The next thing is, like in our hospital, what we have is for our anesthesia related gauzes, when we are using and disposing them, we have a separate bin actually, and a separate set of stock that comes for us in our own, trays and drapes, so that it doesn't really mix onto the surgery site. So we do the biological, the hazard color coding, and that happens straight in the OT. And we have two sets of bins, one for our side and one for the surgical side, so that, we try to avoid mixing into each, and avoid taking that is a very valid point, taking things from the surgical side. You should really avoid that at all costs. And, even if it's done, make sure that it is documented very carefully and noted. So this is all I had to add. Murli sir, did you have anything to add?
Yeah, a few important things here that especially the juniors should note. One is we are not silent spectators. So if the case that happens ends up having a retained gauze and later patient files a case, you're a part of the team. So legally, we will have to kind of answer at some point, because we are a part of the team. The second thing which I have come across as one case was, especially in laparoscopic cases, they cut the gauze, right?
Yes. Sir, you're muted.
Yeah, sorry, I don't know how somebody muted me. Okay, so they cut the gauze in the laparoscopic cases. So there was one case where the surgeon had taken a half gauze, and the count was later taken as correct because they forgot that they had left this half gauze inside. But the integrity of the scrub nurse was so high that something kept disturbing her. This happened around 13 years ago. And she went back home, and then she told her husband, there is something wrong. I'm not able to kind of pinpoint, but there is something wrong. So she came back to the hospital at 11 in the night, took the USB drive or a CD, I forgot what it was, took it home, washed it with her husband. And at 2 o'clock, she realized that there is a half gauze left inside the abdomen. She woke the surgeon up, The surgeon reposted that patient as a dressing change at 6 in the morning, went back inside, removed the gauze. So these are the kind of incidents that do happen, and as anesthetists, we are not silent witnesses. I think this case highlights, and I think silently I would like to thank that person who reported this and highlighted the importance of the entire thing. So I think we can move to the next case if it's okay. Yeah?
Just Murli, one as a corollary, I would like to just add.
Yes, sir.
The issue is that it's not only about gauze pieces. The most commonest issue with us would be a drug mix-up at times. So I would suggest that we also pay attention to the broken ampules and keep them separately from which the drugs have been loaded. So that if you need to cross-verify of an accidental wrong drug being administered, at least it can be verified. Otherwise, you will be searching all the ampules in the dustbin. And they are generally put at a, or they are put it on a closed case and you can never reach them out. So just preserve the ampules also so that the drug-related mishaps can also come down. I mean, just something to add on to what we were discussing.
Yes,
Thank
sir.
you, sir. Thank you.
Right. There's something, sir. We have different plastic ke tasle, what you call, na, for the anesthesia and for the surgical end, so that one case ampules are all broken, and once it's safely out, then we mix it with the main garbage.
I would like to bring a point forward. We had also introduced a different colored gauze for the anesthesia side, so that this change of gauze between the surgical side and anesthesia side shouldn't happen. And I don't know why it was withdrawn, but we did have it for some time. Is that something that can be done, Dr. Murli? What is your...
I think it's probably the management realized the bottom line was getting affected with regards to the color. So probably that's why they kind of went back on that. But as far as I know, there might be systems elsewhere in the world which might incorporate it, but at least I have not heard of any other hospital in India which practices that.
Okay.
Oh, we used to use the blue colored gauze piece for the anesthesia team,
Yes.
but what we have discarded it now because it's double the work. They will have to first color them up and then send them for sterilization again. So that's one issue which crops up, probably extra work. I mean, that's the only thing. And sometimes they will keep the colored gauze pieces which are unsterile for use, especially on the anesthesia side if you're not doing a sterile procedure. So that's where the uncolored, I mean the colored, blue colored gauze pieces used to be kept separately with us.
Thank you, sir.
Thank you so much. That was such a vibrant discussion, and we learned so much. I'm sure all the juniors here have so many take-home points. Let's quickly move on to the next speaker, Dr. Bhuvaneshwari.
Good evening, all. I'm just sharing my screen. Okay. So today there was this another article in the same newsletter which focused on seeing the vein hitting the artery, which is something that we still face despite the presence of ultrasound guidance when we are inserting the central venous catheters. So and it does end up being not just hitting the artery, you might end up accidentally cannulating the artery as well. So this was the case that was described, and so basically during the central venous catheterization of the left internal jugular vein in a renal transplant recipient, the carotid artery was inadvertently punctured by a senior resident under ultrasound guidance, and the needle is believed to have shifted from the vein to the carotid artery during the guide wire replacement, and the dilator as well as the catheter was advanced before the arterial placement was recognized. And so it was immediately removed, and there was a hematoma which was developed. And considering this was a patient who was a renal transplant recipient, maybe would have had an altered coagulation profile as well, which would have been difficult for the hematoma also to settle very easily. So medial needle angulation and guide wire advancement also lack of arterial pressure confirmation were identified as the key technical contributors. So as we move over to seeing or assessing this particular incident, so it was basically the two main contributors were the medial needle angulation, probably during picking up the guide wire, or maybe they have done scan, but then while at the time of the needling, the ultrasound probe might have slightly moved medially, guide wire advancement without any arterial pressure confirmation. So the critical miss is not the arterial puncture, but advancing a dilator or a large bore catheter into the artery. So we really have to move from just considering that if once you're using ultrasound, you're going to be absolutely safe, but it is more about the needle wire dilator safety process. So why ultrasound guidance can still fail is there might be an image hand disconnect. So the probe sees the anatomy, but the hand might drift medially. And especially since we are using a lot of short axis views for cannulating the internal jugular vein. So we generally do not end up seeing the tip or the entire needle as such. Where if you're using the long axis view, maybe you will be able to see the entire shaft with the tip of the needle, but a lot of people still prefer the short axis view. Tip ambiguity, so short axis, there is always confusion between the shaft versus the tip. The free wire passage does not really prove that it's confirmed into the venous placement, so it can also enter the artery as easily. And there is also a point of no return error that once you have put in the guide wire, you have started dilating and inserting the catheter after a arterial injury. So it has to be, so it's not just once you have an ultrasound, you're on an autopilot mode. It has to be paired with real-time needle tip control and confirmation. Otherwise, it's going to lead to complications in the form of stroke, major hemorrhage, pseudoaneurysm formation, AV fistula, airway-threatening hematoma. So, and it's not just the common carotid artery which can get accidentally punctured. It can also be the cannula in the internal jugular vein, which has pierced through and through to the vein, and it has gone into the subclavian artery. So compressing the carotid artery is still possible. Subclavian might not be. So what are the causes for this? So anatomy is so dynamic and it's not a fixed textbook picture. It changes for patient to patient, from proximal to medial. So there is always you have to take your time to do a scout scan before you actually hold the needle, and you will have to ensure the best position where there is low overlap before the puncture, before, during, as well as before the dilatation. So you have, before you move ahead for dilatation, you have to confirm the wire placement in the vein in two planes, short axis as well as the long axis, and confirm the venous pressure and the waveform if you're still not sure. So short axis versus long axis, you have to take your call as to which blind spot you can manage. So what are the strengths of the short axis view is it will show you both the internal jugular vein as well as the carotid together, and it's excellent for pre-scan and overlap assessment. But the blind spot here is the dot which you generally visualize in the vein it might be the shaft and not the tip. So posterior wall puncture may be missed in this. And in fact, in the study which has been quoted in this particular article also, there was a chance of almost, this was in a study which was conducted on residents who were already trained in landmark guided procedures, and they were made to do an ultrasound guided short axis versus long axis catheter insertion in mannequins, and still there was a posterior wall puncture of almost 40% in the short axis view versus almost 19% in the long axis view. So the posterior wall puncture is a very, very significant issue for us, and especially if the vein and artery are overlying each other. Whereas the long axis view, the needle shaft and tip can be followed. Generally, they would require fewer redirections and posterior wall punctures. The blind spot is you are not going to be able to simultaneously visualize the artery, and it requires accurate vessel identification. So generally, you should follow a transverse pre-scan, cannulate with the continuous tip tracking using a long axis view, and verify the wire in 2 planes before you hold the dilator. So the three moments of truth is in the needle. So is the tip inside the lumen, not merely near it? So that you need to always check with a colleague or a senior, whoever is there around, to help you out. That's the reason that you are never doing these procedures alone. Then once you have inserted the wire, you have to again call out whether it's a guide wire, definitely within the vein in both the planes. So with a short axis as well as a long axis view. And the dilator, so have we excluded the presence of arterial pressure before making the injury any larger? So you can always attach a meter and with a waveform to look at whether it's an arterial waveform or a venous waveform that you're visualizing. So has to be a compulsory hand-off pause before the dilator. Probe on the neck, wire seen in the vein, and the pressure that you see is venous, the pressure waveform. So you can use a simple prevention bundle in the form of see, stop, confirm, and dilate. So C is pre-scan. Assess the overlap, depth, and presence of any thrombus. So when you're doing a scan from proximal to distal part of the vein, and mark a safe needle path. Then stop can be, if the tip is lost, then stop advancing. If the wire feels abnormal, if you come across any resistance, stop. And if the blood looks arterial, stop again. Confirm the wire is in the vein in the short as well as the long axis. The pressure of the waveform is venous, and team verbalizes the confirmation, and then only move on to dilation only after confirmation and using minimal force. And if you are coming across some resistance, then again reimage the path. So if you don't see an image properly, no wire, and no wire confirmation, you will not touch the dilator. So if an inadvertent arterial cannulation is suspected, so how are we going to manage them? If it's just a small needle puncture, so withdraw the needle, apply firm direct pressure for an adequate duration, reassess the neck swelling, neurological status, and any airway risk if it has happened, and resite only after the anatomy and the risks are considered. If there is an uncertain placement before the dilatation, then do not dilate. Check the pressure waveform, ultrasound the wire, consider maybe sending an ABG or even a pressure waveform, and ask for senior help early if you don't have one. And if the dilator or the catheter is already in the artery, do not pull out blindly. Leave the catheter in situ, call the vascular or interventional radiology immediately, and urgent imaging and planned endovascular or a surgical repair. So the larger the device, more dangerous the removal is. So you can always turn the incident later into a training once the patient has been stabilized. So team callouts in the form of maintain. So there are these 4 points that you should always look at: maintaining a lateral needle angle, check for venous pressure, confirm the guide wire in the vein, and only advance the catheter if there is no arterial pressure waveform. And you can always go ahead for training all your residents and the co-faculties, colleagues again and again, so that all possible complications that can happen can be done in a simulated control environment rather than directly on a patient, and you might be able to handle those complications in a better way without panicking. Equipment layout should be always checked, and always have an audit metric at the end of the procedure, and also not just the ultrasound use, but the number of complications that can happen. So these are a few recommendations which the authors Sogel et al. Have put up for an ultrasound guided central venous catheter placements. It's a 6-step approach when you're using an ultrasound. So identify the anatomy of insertion site and localization, confirm the patency of the vein, use real-time ultrasound guidance for puncture. So basically you can use the Doppler, confirm the needle position in the vein, confirm wire position in the vein, and then after dilatation, confirm the catheter position in the vein. So if you go this stepwise, you will end up having lesser complications also. And there is always a stop at every check. And the practice guidelines which have come up by the American Society of Anesthesiologists, the task force on central venous access, is based on the type of catheters we have, whether it's a thin wall needle Seldinger technique or a modified Seldinger technique. So you use a real-time ultrasound if only when you know that the needle appears to be in the venous system and you have confirmed it with a manometry pressure measurement or an ultrasound, then you're going to proceed ahead to thread a wire. If not, do not proceed, and confirm the venous residence of the wire with an ultrasound, TEE, continuous ECG, or a fluoroscopy. And only once you have confirmed the wire is in the proper place and it's in the vein, you will proceed with dilator and catheter placement. So these are the summary of the practice guidelines that they have put up with respect to the needle insertion, wire placement, and the catheter. Then how do you guide them and how do you verify them? So the main points for confirming that the catheter is in the vein is ultrasound, manometry, pressure waveform analysis. Then now for checking whether the wire is in the vein, the guide wire would be identification of the wire by ultrasound, transesophageal echocardiography by identification of the wire in the superior vena cava or the right atrium, a continuous electrocardiography with a narrow complex ectopy and or fluoroscopy. And to confirm the catheter is still in the venous system is manometry or pressure waveform measurement. And once the arterial trauma or injury has occurred, if it unintended has occurred, then you are going to leave it in place and consult a general surgeon or vascular surgeon or an interventional radiologist for the catheter removal. And neonates, infants, and children, you have to determine on a case-to-case basis whether to leave the catheter in place and obtain consultation or to remove the catheter non-surgically. And after it has been evaluated and a treatment plan has been executed, you confer with the surgeon regarding the relative risk and benefit of proceeding with the elective surgery that was planned versus deferring it to allow for a period of patient observation. So that is also one thing which needs to be considered, because he has not come for just central venous catheterization. He has come for the surgical procedure. So the take home from my talk would be ultrasound is just a visual aid, not really a safety system. So you will have to build a safety system at your particular institution or follow the established norms that are already there, so that we don't miss out safety at each point of catheter insertion, and we improve our safety techniques while inserting a central venous catheter. So choose the site, track the tip, confirm the wire, and leave the large arterial catheters at the site. So these are my references. Thank you.
Thank you so much, Dr. Bhuvaneshwari. That was very well described, explained, and brought out a lot of important points when it comes that ultrasound is not foolproof. You have to use it in the right way and in multiple ways in order to confirm our techniques. So I'll open up the floor for discussion. Murli sir, would you like to start us off?
I would like to start by thanking Dr. Bhuvaneshwari because Dr. Alka, for some due to emergency, she had to travel elsewhere. So Dr. Bhuvaneshwari stepped in at the last moment around 2-ish this afternoon, and I don't think I can believe that she took just 3 hours to prepare these slides. So thanks a lot. Wonderful, discussion. So let's kind of open the discussion with so many other eminent people around. Pankaj sir, would you like to add something?
Yeah, there are a few very important points, if you permit me to put them across, because I think they have not been mentioned in guidelines, and somewhere some points are missed, and that's why we still continue to have the arterial puncture. The first thing is that at many of the times, the veins may be collapsed. So it's good idea if the patient is on positive pressure ventilation to keep some PEEP so that the vein is little distended when you puncture it. Or you must have a head down tilt to expand the vein so you have a better diameter to puncture the vein. Now the most critical point, I hope you will excuse me to say that, is that when you puncture the vein, with the pressure which you apply, the vein collapses, and then you go and puncture the posterior wall. I think none of us can visualize the needle entering the vein. It is more of a ultrasound assisted cannulation rather than an ultrasound guided cannulations. So at the time when the needle punctures the anterior wall and enters the vein, that part is never visualized in the ultrasound. And the reason is that while puncturing the needle, either you do not have a skin puncture, and if you don't have a pre-existing skin puncture, you apply extra pressure. That extra pressure which you apply to puncture the skin, and when the needle goes in, it it goes and it collapses the vein and then goes and hits the posterior wall. And at times, even the ultrasound probe is kept a little bit harsher or with a greater force onto the vein, and then it again collapses while you are puncturing the vein. So the trick here is don't catch the syringe which is attached to the needle and keep aspirating and pushing it. That requires a larger or a greater force to puncture, and that collapses the vein. The way to hold it is hold the needle near the skin. If you hold the needle near the skin, the force which you're going to apply is very well controlled, like you do for epidurals. So if you hold the needle towards at the point where it is entering the skin, once you have punctured the skin, you will be able to see the anterior wall. You will also be able to see that the needle tip is now entering the vein. That part is, in the majority of these situations, is missed, and you collapse the vein with your pressure, and then of course end up with the posterior cannulation. So this is more important when you do it for small kids. And please remember these things, because these are not written anywhere. These are practical skills which you see and you try to see. Because anytime when I like to look at the needle entering the vein, most of the time the needle has already gone across, and we are just focusing at guide wires and other things. Why? Those things can be done. But the critical point is make sure it is ultrasound guidance and you see the needle tip entering the vein rather than visualizing after the vein re-expands. Thank you, Murli.
Yes, sir. Thanks a lot. Archana, would you like to add anything?
I think someone was trying to speak. So I wholeheartedly agree with what Kundra sir says. These are like practical tips and points that happen. You don't read them anywhere, and they're not told actually when you're learning how to secure them. And, especially when the juniors are starting out, they're very excited the first time they're using ultrasound, and they use a lot of pressure when they're trying to secure these lines. They should be very careful, especially in hypotensive states or low cardiac output states, wherein it can get kind of tricky. So point well noted, Pankaj. Thank you so much for that. Would anyone else like to add any other points?
Can I say something, Archana?
Please, ma'am.
So what Kundra sir said, that exactly happens. And also at that point, when we are trying to apply pressure and prick the skin and the vein, at that point of time, the contact of the skin and the probe gets lost and the image gets lost. That frequently happens. So if someone could help us out with how to do this, especially when we are doing the out of plane approach.
So Dr. Vandana, if I can add to that, I thought I
Yeah.
briefly mentioned it. What you could do is you take a large bevel needle, like a 20 gauge, put it almost horizontal to the skin, and see the point where you want to make the puncture with your SVC cannula or a needle. So have the skin puncture performed before you attempt the needle puncture with the CVP needle which you have there. So I will put the probe, mark the point where I need to puncture the skin, and then remove the probe and just puncture the skin there, so that the skin resistance is gone. So as soon as I take out my needle from this CVP set, I'm beneath the skin. And then I keep the probe and then align my needle and hold the needle as close as possible to the skin. And with a millimeter thrusts, I try to puncture the anterior wall and then see that my needle enters the vein lumen, and the lumen is not collapsed. If it is collapsing, I will still reduce my pressure at the ultrasound probe or at the needle point, trying to screw and then going in slowly. So these are certain tips. If you can take it from me, I'll be happy.
Yeah.
Thank you.
Yeah. We'll try this the next time, sir.
Can I add something, sir? Murli, sir?
Yeah,
Sir,
sure.
Senthil, please.
Sir, I think when we use the ultrasound, so we can see the approximate depth of the vein from the ultrasound, and we can have an approximate idea of how much the needle can pass. And when we pass through the wall of the vein, we get a definitive giveaway. So we stop in that first giveaway, so that most of the times you are in the vein. That is one thing. Second thing is about the long axis of the probe instead of the short axis. So because we have varied sizes of the neck, thick neck, short necks, and to accommodate the linear probe in that short neck would be a problem for the long axis many a times. We have to struggle to needle it unless we have a hockey stick probe. So that is one thing I wanted to add. So how to come over it when we cannot accommodate the probe for a long time.
Senthil, you had good points there. One was the depth that you can, estimate how deep the vein is. And the second was, can we do long axis in short neck patients, right? That is your question. Well, I think there
it will
we're
be
again
difficult to accommodate the probe and then
yes.
go on.
Yeah. Yeah. So the only other thing where what you can do there is rocking the probe. Apart from the three alignment, the rotation and the three art maneuvers that we talk about. The other thing is you can rock the probe a little bit. And in my point of view, I think the two cases which prove to be a little challenge, the one like what has been reported here with a renal failure, the venous pressure is very high. I think in those cases, it's very difficult to actually ascertain where you are. And sometimes if people think that it's because it's renal failure, I'm getting what looks like an arterial thing, but actually it's a vein, then that is a problem. The second is in hypovolemic patients, as Pankaj sir was mentioning, if you do not give a head down tilt and fill the vein, a 10-degree or a 5-degree tilt is more than enough. No need to give very steep Trendelenburg. But just filling up the vein will make a huge difference because most of the times, as Pankaj sir was saying, you'll go through and through the vein. And also identifying the spot where the artery is not right behind the vein. That's another trick because even if you go through and through the vein, you shouldn't be going through the artery. And of course, in our experience, we would have come across many cases where people have put central lines in the artery, people have put, dialysis catheters in the arteries. And I know somebody who put it in a liver transplant patient in the carotid artery. The transplant was canceled and they had to undergo carotid surgery. So these kind of things can happen with even the most experienced of anesthetists. It's not just the juniors. It is just a tired anesthetist who has worked overnight or somebody who is disturbed otherwise or somebody who's trying to do it fast. So these things can happen to any one of us. So irrespective of the stage of career, I would say we have to be extremely careful with these things.
Yes, sir, agreed.
Just one more input. So what I do, I make sure that to track the guide wire, basically before you pass the dilator, in the longitudinal view and also in the short axis, you track the guide wire in the IVC before, the IJV before you pass the catheter. But the comforting thing about the discussion is, very often I struggle to see the needle going into the IJ. So it's more like like Pankaj sir said, it's more like ultrasound assisted cannulation than ultrasound guided. So I always think, even after so many years, it's not every time that I see actually the needle entering the vein. It's like more I map out where the vein is, come somewhere close, and then puncture the vein.
Yeah. Manohar, the trick is just like how we do an out-of-plane block, is to track the shaft of the needle downwards till we lose the hyperechoic dot. And where we lose the hyperechoic dot is where the tip is. So if you do it slowly, actually you can see the tip. You can see the tip entering the needle in the vein. And using longitudinal, view, long axis view is definitely helpful. We
Yeah.
haven't discussed subclavian axis here, which again is a
Mhm.
completely different cup of tea. We have just been concentrating on the IJV and the carotid, but subclavian and ultrasound axis, subclavian is completely a different skill set, I would say. It's not the same as this because you'll be in long axis there and you'll have to go in quite lateral, more like how we do a costoclavicular block and a little bit lateral. So I think we had a wonderful discussion today, and it's been a good 1 hour of wonderful insights about two important aspects of safety. So Archana, over to you.
Thank you so much, sir. Thank you so much, Dr. Pankaj Pundra, for attending and giving us those lovely anecdotes and small pointers also from your experience. Thank you, Vandana ma'am and Dr. Manokant and Dr. Sanjana for also sharing your experiences, and Dr. Sendil, of course. I'm so happy that, even after so many days, we still have so many people attending, and I'm sure we have young postgraduates here also. I hope you do take back. And also, of course, last but not least, our two speakers, Dr. Bhuvaneshwari and Dr. Yogesh, who highlighted very important aspects which might be directly or indirectly related to us, but no more, they supplant that an anesthetist role in the OT is much more than just a standby. We have a lot more to offer and a lot more to take responsibility for. So thank you so much, everyone, and look forward to meeting you all again in our next session in the air rounds of 5. So thank you on behalf of the Patient Safety Forum. Thank you, Murli sir and Sunil Pandya sir also.
Just
you
a
very
last
much.
thing, yes, just to remind everyone that they can download the doc app if they have not done it so. And the last two AIR rounds that we had, we made people report incidents to test the technical side of the app. But today we're not testing the technical side, but I would still encourage people to report any incidents that they come across, however trivial it could be in the last fortnight or so. And the panel of reviewers are there to kind of go through it, and the editorial team and the creative team are ready to kind of get it into the next newsletter. So thanks a lot. Thanks, Yogesh and Dr. Bhuvaneshwari. Thank you very much.